we consistently apply what we already know, right? We know a lot already. If we are able to consistently apply them, I'm sure we would be reducing by half at least all the burden what we see today in India and other global South countries, which are represented today by many colleagues joining. The science is not the bottleneck, it looks like, but the implementation still is a big bottleneck. And that is what is the biggest challenge we all together had to solve. In the second session by Dr. Bhavani and Mr. Krishna, took us beyond the operating table. They showed that safe surgery depends equally or even more on a robust instrument reprocessing, reliable sterilization, strong CSSD systems, and unwavering quality assurance. Infection prevention does not stop when the incision is closed or even when the instruments leave the operation room or operation theater. In the third session, Dr. Kalyani has reinforced that SSI prevention is never the job of one person or one department. Rather, it is a shared responsibility that begins with patient optimization before surgery and continues through disciplined post-operative surveillance. No single intervention can replace consistent teamwork and reliable execution. So, taking all that together, these sessions deliver one clear message to my mind. That is, the evidence and SSI bundles are already in our hands. What we need now is the capacity, the systems, and the daily discipline to turn the knowledge which has been provided by these wonderful people into practice. So that is exactly why we are here today, again congregating in order to deliberate further, to move from what we know to how we can make it happen. And our distinguished panelists will share brief opening remarks, after which we will explore in focused rounds. There are going to be 4 rounds today, and we will explore why do we still see SSIs despite knowing what works. And the second round, we will be deliberating on the leadership, systems, and culture. Either they enable or undermine the IPC compliance. And in the third round, we will be requesting our esteemed panelists to dwell us into the real-world practical challenges the teams face every day, and probably the practical tips from them on how to overcome, in addition to what already they have shared during their presentations in the past. And in the fourth round, then we would be talking about what we must do next in order to break the chain of infection more reliably than what we are doing today. So I guess this is not just another discussion. It is probably a call to translate evidence into everyday practice so that fewer patients experience preventable harm. So let's begin. As I said, over the last 3 masterclass sessions, each of you, all the panelists, of course, today, unfortunately, Dr. Sanjeev and Dr. Mriganka, due to unforeseen and exigency, they are unable to join us, but an able, equally important colleague, Dr. Ranjit, would be replacing them or substituting them. I'm sure his insights are going to be very powerful in order to make it happen. So without much ado, let me start with a very provocative kind of question to all the panelists so that they can give their opening remarks. So my question to all of you, Dr. Kalyani, Dr. Ranjit, and Dr. Bhavani, is that do educational initiatives like this masterclass truly improve patient care, or do they simply reinforce what professionals already know? If it is so, if it is going to just reinforce what they already know, how is it going to improve our practices? What is your call on that? And what more must be done by hospitals, professionals, uh, and professional societies, healthcare leaders, policymakers, or even the industry? Today we have SanMed Healthcare actually helping us to bring all of us together. How do all these stakeholders do? What do they need to do in order to ensure that education and the training is going to translate into measurable improvements in patient outcomes? Over to you. Maybe we can start with Dr. Kalyani, followed by Dr. Bhavani and Dr. Ranjit. Over to you, madam.
Thank you very much, sir. It's nice to be in this session discussing from an anesthesiologist point of view. So when you said, does Masterclass help? Yes, it does help. It is again, it's like a revision. It again draws idea and attention to SSIs, which sometimes when we work daily, it becomes actually like a knee-jerk reflex. We just go about doing it without actually getting involved. So here, I think most importantly, for example, I'll take the example of the WHO checklist. Since 2009, they found that 30-day mortality decreased from literally 1.5% to 0.8%. So complications down from 11% to 7% when they introduced. In 2014 in Canada, when they did, again, there was not much change. So it was, and then again, when it was checked how the team was performing at every level, they found that when the team as a whole is involved, the attitude, when there is an increased ownership, again, all the infection rates, complications came down. So it is not a simple checklist. We have to own it. It is more than ticking the boxes, it is communication. So just in this last, I think 20, less around 18 years, the WHO checklist has itself proved that we as humans become complacent. So I think a regular auditing and feedback systems that would kind of awaken what is already known and improved upon. So yes, education does help, but unless the ownership and attitude of the whole team, which is encouraged, and encouraging people to speak up if something is missing, that would go a longer way in
Thank you, ma'am.
maintaining the system co.
Thank you, ma'am. I think that's a very wonderful insight. Revision is the word. I take it as very important point, and also giving a little nudge to the people in order to wake them up and not to see the other way when the actual problem comes, but thinking how I can apply my knowledge in order to get over that problem and move forward. Dr. Bhavani, over to you, madam.
Yeah, good evening, everybody. First of all, I would like to thank SanMed for taking this initiative and giving me this opportunity to be part of this masterclass series. It's definitely 200% program like this gives continuous medical education and continual improvement. And thanks to the SanMed for taking this academic initiative, educational activities definitely reinforce good clinical practices and prevent hospital-acquired infection, which we are facing in every day in the hospitals. Sustainability is possible only through continuous medical education. We all know that. And for these measurable improvements and for better patient outcomes, we should have workshops, bedside trainings, continuous conferences. Also, competency assessment should be done at the hospital level and also have checklists in place and have feedbacks and audits to be done regularly.
Thank you very much, Dr. Bhavani. Wonderful, madam. I think, there is a big role to be played by the industry, like SanMed and other companies who are working in this space of IPC. in order to develop such programs which are going to integrate into the CPD of the healthcare institutions, the continuous professional development, because they are the people, who develop the products. We are the people, who actually translate the evidence and the products actually into the practice. I think this collaboration is going to make our practices probably better. So Sandmed and other companies, who are listening, take note of, what Dr. Bhavani said. You guys need to do more than what you're doing currently. Dr. Ranjit, over to you, sir.
Yeah. First, I thank Rangareddy sir and Dr. Kalyani madam for giving this opportunity. So your question about educational initiative, undoubtedly, yes, they improve the patient care and they have an impact. But I feel what actually is more important is transferring the knowledge to changing behavior. I mean, like most of us as healthcare professionals already are in exposure to the principles of infection treatment in bits and pieces, but the challenge is not the knowledge deficiency, but it is the implementation of the translation into our practice. So what transforms this sustained practice is not just standardization across all the organizations, all the institutes, performing regular audits, taking help of some organizations, having regular audits of what is the practice being happening to have a constant progressive growth and a constructive feedback. And ultimately, it is a leadership commitment. Like at my place, Kalyani madam has that role. So we are all in place and we follow it. And finally, the accountable. So the teaching should not end in the lecture halls, but it should be actually reflecting in the operating rooms to actually lower the SSIs, because finally the patients who are to be benefited more than this.
I can't agree more with you, Dr. Ranjit, for that perspective. The behavioral change, and which had to start with us, because most of the times when we talk about behavior, we think it is the rest of the world other than me who had to change. And second very important point what you have raised is that how do we bring in the good practices into the OT, right? How do we ensure that we are going to have the discipline in terms of ensuring that the knowledge is translated into action when we are on the table in the OT, right? So before I let you go in continuation, Dr. Ranjit, maybe you will be the opening batsman probably today for the round one. I would like your perspective as a surgeon. You had been into orthopedics for so long. What are the most common reasons evidence-based SSI bundles are not getting the traction how we would love to see them? What is your perspective generally on SSI bundles and why they are not getting the traction?
True, sir. From the surgeon's point of view, everyone knows the evidences are clear. The guidelines are clear. The problem lies in inconsistent execution. This can be of various reasons in various organizations. It could be because of variation in practices from nursing homes to corporate hospitals, from teaching institutions to government hospitals. You have infrastructural challenges, you have financial challenges, and sometimes it is so obvious that even time pressure to the surgeons, to the team, wherein they need to perform it faster for the billing. And there are many other obvious reasons of this time pressure that leads to shortcuts, maybe some challenges in forgotten instrumentation or something like using improper practices, which are not of standard guidelines, right from skin preparation to autoclaving. And it could also be a poor communication. Sometimes we actually say my team that no, don't give antibiotics because I'm taking biopsy. That doesn't mean that don't give antibiotics even after the biopsy. So miscommunication, no standardization no platform to actually communicate it because every case is not the same. This is mainly because of inadequate documentation. So we have to see that the SSI bundles as a checklist exercise rather than a patient safety culture. We have to make sure that these reflect and transform finally, because in trauma surgery, we just don't deal with clean cases. We also see contaminated cases in comminuted fractures, infections, fracture-related infection, prosthetic joint infections. And we need to be more adherent to the practice guidelines because every misstep may appear small, individual level, but collectively they significantly increase the burden, morbidity, mortality, and whatnot.
Absolutely, doctor. I think it's a domino effect, and also it is so-called amplification. One wrong done at one place can have an amplified elsewhere or amplified across the chain. I think that's a very, very valid point. And also, I would like actually to ask an extension question. You talked about standardization in terms of SSI bundles. If I am not wrong, the Surgical Society of India, Surgeon Society of India, or Orthopedic Society of India, you do have these standardized guidelines, if I'm not wrong.
So yes, we have in terms of clean, sterility and all, but there is a hospital infection control which has to be more in place, particularly in our setups. So the antibiotic guidelines, we still are in need of streamlining all these because this is very important in preventing SSIs. It's just not sterility, it's just not culture. But the guidelines are in place. The guidelines broadly take care that yes, you need to take care. But again, still coming to ground reality, the practice point of view, we are still lacking so many things compared to the Western world. And ultimately, most of us do agree that these are all infrastructural challenges, but we need to overcome them because more than the burden we have, I think it's no more. I mean, like in no time, we can definitely overcome.
Yeah, what you are essentially saying is, yes, guidelines are there. They are general in nature. They had to be customized to the local situations, depending on your infrastructure, your people capacity, and the kind of surgeries what you do, etc., etc. Thank you very much for wonderful insights, Dr. Ranjit. I will next go to Dr. Bhavani. Madam, from your experience, what are the most common barriers hospitals face in implementing evidence-based IPC practices, and how can these challenges be overcome?
So hospital often knows what are the evidence-based guidelines to be followed, but they have their own challenges. It depends on what staff, what limited knowledge they have, and what training needs to be given to the staff. So I feel that whenever an employee joins hospital, he should undergo induction and orientation training as per the guidelines to be followed for the SSI. Also, what are the hospital protocols which needs to be followed, whether it's a nurse or a technician and surgeon, anesthetist, because these are the people who are involved in the operation room. And also poor adherence to IPC practices. This also needs to be taught to every employee who enters into the OT. There are a lot of things which needs to be taken care to prevent SSI. Also improper supply chain management. That is, resource constraints are common. Whether it's a government hospital or private hospital, this needs to be taken care. They have to have proper disinfectants in place, and also the staff should be adequate. Also, we should think about organization culture and resistance to change. This is commonly seen. Nobody wants to change. We have to do what is called as policing. Come on, you are entering without wearing gown, or you're not wearing a sterile gown. So these are common factors, especially in private hospitals. See the doctors and surgeons and the nursing staff come out with the scrubs and crocs, which I never liked. I always tell them to use sterile whenever they enter inside OT. So for this, we need to have strong leadership commitment. The leadership should be really strong, because without management help, even the infection control cannot do anything. Inadequate surveillance system. We have to see what are the SSIs, which are the common department which is developing the surgical site infection. Inform to the management, give them the feedback. What is the common organism which is causing infection, so that action needs to be taken and it can be prevented. Poor multidisciplinary communication. There should be communication between the anesthetist, nurse, surgeon as well. If there is a remote infection, it has to be treated. When anesthetist is going for PAC, he has to tell that the sugar levels are high or his urine is having infection, he cannot be taken for surgery. This communication has to happen to the surgeon, which can be postponed and prevent infections. Time pressure and heavy workload. This is also a common scenario in all hospitals. So we need to streamline workflow and also have adequate staff for all this. And the last point I would like to talk is inappropriate antibiotic prophylaxis. We consistently say them that cefazolin is the best drug to be used, but then I keep seeing surgeons and anesthesists using different kinds of drugs for prophylaxis. Also, correct timing. They have to be given within 1 hour of incision, which needs to be followed, and this needs to be audited across hospitals.
Thank you, ma'am, for that wonderful insight. Ma'am, just probably you can take it as on a lighter side. When the people actually put on you a sticker saying that police is coming, what do you feel and why does it happen? How do
I
we
don't
kill
mind
that?
doing it as far as the patient outcome is the best. I care only for my patient.
That is very, very positive
Yeah.
way of taking things. Thank you so much. Dr. Kalyani, I will come to you now, ma'am. How can anesthesia teams, which you lead, work more closely with surgeons and nursing staff to ensure every component of SSI prevention bundle is completed? Your views, ma'am.
Yes, sir. So I think again, I would like to reiterate communication and mutual respect. So thankfully, I'm very thankful to our surgeons. We are all literally on the same page where the patient care is optimum. And as recently as last week, we had to postpone Whipple's, though he was fine. His WBC count was 21,000, which we alerted.
Wow.
And we kind of got that down before we took him for surgery. However, that interaction is there. It's a tight list we cannot do. And most importantly, again, I would like to reiterate, I don't know how much Ranjit will let me know, the number of cases which we have had infection coming back to the theater for surgical wound infection have been very little. I think in the last 5 or 6 years we have had, I think, only 3 cases which had to come back and resuture. In saying so, I can't say our surveillance is very good, but this is my information that we have got. And this, I think, is because I am, like a madam was saying, strict. I am, maybe, I don't know what Ranjit will say, I'm a dictator. So but luckily our nursing staff have been very cooperative. Our antibiotic goes in, as madam has said, literally before the incision. Strict compliance to our WHO checklist has been there. And our CSSD is also very strong. So thankfully, these have been done. And from my side, as madam has pointed out, besides the antibiotics, we see that the hemodynamics are well maintained and strict warming of the patients is done, as well as oxygenation, so, and glucose control. So obviously in an emergency, blood glucose is not under control. We optimize for a couple of hours and see that it comes down, so that the amputation case, which is a semi-emergency, we optimize and then we take it. So those also have been doing quite well. So they had infection, but there are no super added infections. So I think the teamwork and mutual respect has gone on to a certain extent. And sometimes, we are also giving opportunity to the juniors to say, yes, this could not be done and this can be done better. So there is nothing which is absolutely right. And we have to be open to criticism where things are not going as it should. So I think that also is part of why we are improving. We are not perfect. We are improving day by day, but I think we have set some quite good standards. If I may, Dr. Ranjit, how many infections have we had in orthopedics?
Truly, as per your report, madam, but if I tell more, I know you'll not give me next case.
No, please go ahead.
No.
Feel free.
Sorry, it's a joke. Sir, that's the true commitment of a leader. She sets the tone in the OT. We do follow it. It is actually like a surgeon anesthesia in a teamwork where she values infection prevention, and as a senior, and we always followed it. Our association has been since 10 years. So that actually rightly right synchrony of environment where it is just not a doctor, it is nurses, cleaning staff, CSSD, post-operative care, nurses everywhere, and finally the patient himself. A lot of factors. I mean, like we cannot attribute only to OT factors, but yes, they were set right and rest followed. And it was, touchwood, it was very good for us. And we continue and we train the same to our students. And that's the spirit, sir, actually.
Absolutely. Kudos, actually, that clearly shows, how mutual respect and trust in the team is going to bring the wonders and make actually patient safety a reality. I think, there cannot be a better example than what you has actually had a dialogue in live with all our people, who are watching from all over the world. Um, Dr. Kalyani, I think, one of the points what you have talked about, the teamwork, and Dr. Ranjit has very clearly mentioned, somehow when we talk about IPC or the patient safety, we always actually pivot on only doctors. But when 80% of the work had to be done by the other colleagues, either they are nursing staff or others, I think giving them due role, empowering them, and also giving that respect is going to bring all the difference. I remember as an intern how we used to be scared about our OT in charge nurse,
Yes.
who was the matron and who was the queen of the OT, and she used to rule that. And of course, that kind of actually a little bit of dictatorship is probably sometimes required in order to bring the discipline in the people. And another point, what you have raised, ma'am, is we are not mathematicians where there is 2 plus 2 is 4, right? It is an exact science. We are into clinical science and medicine, there nothing can be, black or white. It is always in the shades, like in that book of 50 shades or whatever more, right? So we should know those shades and, we should operate and we should be recalibrating our work actually to ensure that we have better practices. Some of the words which you have pronounced today was leadership, the systems, and also the culture and behavior. Now, my next round would be exactly that, where I would be putting some questions in relation to the leadership, systems, and culture, how that is going to actually make a difference to the IPC practices in our healthcare systems. Dr. Ranjit, probably I would again start with you. How important is surgeon leadership in creating a culture where every member of the OT team feels responsible for infection prevention? You already mentioned about actually having that collaboration and also bringing the team together. If you can elucidate further, I would be grateful. Over to you, Doctor.
Yes, sir. Thank you. So as reiterating what Madam has told and what we discussed earlier, so it has to be a combination of mutual respect to the team, because it is never a one-man show. It is not that doctor does always. It is everyone's role that is making a success in practice. But at the same time, as you reiterated, sir, it has to be one has to lead the tone in a monarchy, in a dictatorial form, so that things are set into practice. Maybe once everything is in practice, you need to change the culture to good professionalism, good leadership. The good leadership means encouraging every team member, right from junior most nurse, housekeeping, ward boy, technician, everyone to speak up if they find something that the sterility is compromised. They need not be offended or they did not get frightened to point out at the senior most person in the team that if he has touched something unsterile, it is for the patient safety. That culture should be set up as a practice. So for that, respecting the healthcare professionals, it is the work dignity, empowering the nurses, technicians, housekeeping staff, following the protocols without exception. There is no exception for a doctor. There is no exception for a senior nurse or someone. So all this comes by leading by example rather than by authority. So this culture has to be set in all the OTs. And this will safely ensure that the psychological safety will be there in the team, and that will help in prevent infections. I feel that a good leader should take care of all this for the best of the practices, because we all know that everything exists, everyone knows it, but to implement, we cannot do a daily audit. a standard possible practical way is to train everyone that please point out at others' mistakes in a polite way. And whenever in doubt, it is always better to redo. Go back, wash back, come back again, change your gloves. No harm. No harm than a bloody bug.
Thank you very much, Dr. Ranjit. Very powerful words. I hope our colleague surgeons who are today are going to take your message not with a pinch of salt, but with words of wisdom, probably as words of wisdom, which they had to implement. Because, we all know while we say these things, but sometimes the ground reality is very, very different where the nurses or even the registrars or the SRs or JRs, they feel intimidated actually to go to a star surgeon and speak out. They fear actually of repercussion or some kind of action probably which may not be good for their career. In probably one sentence, what is the kind of advice you give to such people who feel scared or who feel intimidated actually to bring out the truth? As a surgeon, what do you say to them?
Sir, I think it is more than for them. It is for the senior leads or someone because it is we have to change. I mean, like giving a safe practice, giving a safe freedom. I mean, like we have to have adequate classes that we organize, Kalyani Madam organizes at our place for all the beginners. There has to be orientation programs. Maybe in the orientation programs, when the senior surgeons, senior doctors do take the classes, they get that psychological strength that yes, we can do this. Sometimes they get reiterated with the practices, and sometimes they get the confidence that this doctor told me to point out. Yes, I can point it out. I mean, like the best practice is always a orientation. We know that it is not a calendar year. Everyone doesn't start or join on a day one, but we can ensure that these classes do happen very frequently, and we can make sure that everyone who joins new do attend it as a standard of practice. No harm than not doing it. So once in 3 months is a good time, orientation class, small batch, which is more interactive, and that will address most of these issues.
Sure, doctor. But probably giving that assurance, guys, don't worry, come. We are here to hear you. You are actually as good as me in ensuring the patient safety. Probably those are the reassuring words what probably could come from the team leaders or the surgeons actually, to remove that factor of fear from the people, who are not very privileged. Probably that is how I would look at. Dr. Bhavani, I will come to you, ma'am, now. What are the practical strategies a hospital can adopt to ensure the guidelines are consistently kind of implemented across all the departments?
So, as Dr. Kalyani mentioned, we need to have a surgical safety checklist in place, first of all. Every surgeon, every surgery is done, that checklist needs to be filled and cross-checked. So there should be one leader in the OT, either the surgeon or an anesthetist, we don't mind. But that particular person should have a control over the operation theater, and also infection control should get in touch with them and see that everything is taken care. So I think that leadership is very important. How I wish, as Dr. Ranjit said, that doctors come for class. That is not possible always. If I tell them I'll take a class, I'll see only 2 or 3 people coming there. So it's not very easy to accumulate surgeons to take classes, but how I wish that this will happen, because it is never taught in MBBS about infection control practices. So doctors often are ignorant about infection control. Only over a period of experience they'll get it, but the new junior doctors, they're not aware of infection control practices, and often see that, especially in orthopedic surgery, the K-wire, they keep getting needle pricks. Needle stick injuries are often happening because of K-wire. They report to me only when it is a positive case. Otherwise, I guess I'm missing many of them. So such things should be taken care. So regular bedside training, ongoing education, and training is a must. Continuous periodic surveillance, of the OR, of the infection, of the surgeon commonly causing infection is also very, very important. And strengthen leadership commitments. So as I said, one leader is very important, and then the management, they should report to the management. Provide timely feedback and address gaps wherever necessary, whether it is a CSSD issue or a antibiotic prophylaxis issue. We have to know the feedbacks and gaps should be adequate resources are also very, very important, and implement multidisciplinary collaboration. So we should have monthly meetings and also subcommittee meetings. If a particular surgeon or particular group of patients are having of an infection, then we immediately have a subcommittee meeting where exactly they're going wrong, or where the process is going wrong, or is there any resources shortage. So all this should be taken care of.
Thank you, Dr. Bhavani. Thank you very much for that. And Dr. Kalyani, I come to you, ma'am, to core of your profession, right? What is that you would like actually to give a message to the anesthetists who are in the audience and beyond, who are going to review this video probably multiple times at a later date? What role they had to play in strengthening WHO surgical safety checklist beyond simply completing documentation?
Yes, sir. So I think basically what happens is as doctors, we limit ourselves. Like as an anesthesiologist, I say anesthesia is my role, I won't go beyond it. And a surgeon says surgery is my role, I won't give. So OT belongs to all. So if you take ownership and take everything into perspective, including the pre-op. I'll give you a small example. The patient had IV antibiotic going in the pre-op. Patient is telling the nurse, I am allergic to an antibiotic. I am allergic to an antibiotic. She says, no, this has been prescribed by the doctor. I am putting it in. So a patient is telling her, I am allergic to the antibiotic, and this nurse is not listening. We have to listen. I think after a point when we become senior, we stop listening. So listen to the patient and listen to the junior most. Sometimes the most hesitant person is making the strongest point. So I think communication has to be there. It has to be an equal. I mean, you are a human being, adult, you are another is a human being, adult. That hierarchy systems has to be diluted a bit so that we can listen to what is happening. And similarly, the checklist is a communication system and not something to be teched. I feel anesthesiologists play a big leadership role in binding things together. Like a surgeon is like to a brick. We have a couple of surgeons, it's bricks. And anesthetic is like the cement, where you're bringing it all together. I mean, at least I see my role like that, to bring it all together, where I know what is happening with the patient, what is happening at the surgery, and how much extra care we need to take. So a diabetic patient with several problems, we would be more alert to infections. And from my side, oxygenation, most importantly, keeping the patient warm, especially in the winters, in an air-conditioned theater, the pre-op warming, keeping it warm so the perfusion at this tissue level is good. The WBCs are acting well and maintaining the sugars. And most strictly antibiotic. Like if this, we are given a pre-operative antibiotic, if the surgery is occurring more than 4 hours later, we have to see the two half-lives are done, and we might need to redose the patient. And thirdly, major blood loss more than 1500 ml, we need to give another dose of antibiotics. So within our domain, these we can very clearly use. So there's one study where they said if there was a 2-degree decrease in temperature, literally 11% was the increase in infections. So something, this is not quantified and not seen. So these kind of things make a major role, that despite the surgeon CSSD being very good, best surgical technique, but if there was hypothermia, that could have added to the SSI, because so there are so many other confounding factors. We play a major role in that, in seeing that those things happen. So my
Great
thing is,
insight,
we
ma'am.
do it. Yes, sir.
That's actually, hard hitting probably for a lot of our audience to know one simple statistic which
Yes.
can actually make us stand up and take notice of it. 2-degree increase, 11%. Guys, please note it. and then probably we will never forget and never do anything actually to make anything wrong. Thank you very much to all of you, the audience. Probably in next 15 minutes, we will be kind of, completing the question round. So start actually shooting out your questions. I'm sure, you would be eager to clarify your doubts from the eminent panelists, whom we have today. Dr. Kalyani, now moving from, that leadership and, where we are and all that stuff, probably for our audience today, it would be more important actually to also hear what are the practical challenges, we face in our day-to-day work, right? All this, hyperbole about the guidelines, the philosophy, strategy and all is okay. But, we have our own practical challenges. From your perspective, madam, what are those, challenges which you see are very practical, especially when it comes to emergency surgeries, right? And usually anesthetists and others keep complaining that there is a very little time given for patient optimization, right? um, and in those cases, you feel that you are under pressure, you had to compromise, etc., etc. What is your view on that?
Again, coming to emergencies, I think very few true emergencies exist, like, cesarean section coming with severe fetal distress. Those are the ones which we do in 10 minutes or 20 minutes, or a ruptured aortic aneurysm. Those are the ones which need very little time. So the other emergencies, let's say an orthopedic surgery, which fracture, which needs to be stabilized, we have a couple of hours. So in those couple of hours, let's say the blood sugar, I can optimize the blood sugar. I can see that, small things, instead of shaving, the clipping is done, which I can give the correct antibiotic as per the hospital policy. So there is so much that we can do, and WHO checklist doesn't take more than a minute. And it gets everybody on the same page. So in true emergencies, still we can optimize a bit. And the ones which I cannot optimize, like a cesarean section, after the anesthesia has started, I can definitely give the antibiotic. So in my hands, I have the antibiotic, I have the temperature control, I can optimize the blood sugars. Coming to optimization, let's say of smoking, alcohol, that is protein intake, that we cannot do, but major things we can do. And in emergency, we continue to do it. And that would be my summary. In emergency, I can do this and we should do it.
Good, ma'am. I think you're taking it as a positive,
Yes.
you're giving a positive spin to it. But
Yes.
As I understand, many anesthetists, they feel really very unhappy when they are given very little time to really stabilize the patient. Good that you're taking it in a very positive sense.
No, sir. If I can just say
Yeah,
a small
please.
thing. In an emergency, life or limb is very important. So
Yeah.
that is where, antibiotic becomes a little secondary, but it is still done. So
Absolutely.
life takes prerogative.
Absolutely. I think, we always need to look at what is our priority. At the end of
Yes.
the day, when it is a question of, life or death, we can't actually stick always to protocols.
Yes.
Sometimes we had to deviate in order to save the life first, and then look at, how do we follow on and follow up the case. Thank you very much, ma'am. Dr. Bhavani, over to you, ma'am. When we talk about audits, feedback, and also the staff education, uh, what role all these things play in strengthening compliance with IPC practices across various departments in healthcare settings?
So they all go hand in hand. Regular audits or feedback or staff training, they all are complementary strategies that strengthens the compliance. So we have to do regular audit, whether it is a hand hygiene audit, environment and cleaning audit. Like we keep telling the OR staff that after every surgery, minimum 10 to 15 minutes gap, they have to clean it. So this also needs to be audited. What disinfectant they're using, what mop they're using in the OR and what mop they're using in the corridor. All this needs to be audited. This increases the complaints and decreases the SSI rates. So we have to give feedback about all these also, whether which OR they're not been cleaning well and which OR they have been there. If there's an SSI across hospital, we go and track which OR the infection has come from. So we go and cross check whether it was audited, whether it was being cleaned regularly on regular basis. So that identifies the gaps, trends, and high risk areas across different ORs. So constructive feedback again highlights strengths and recognizes good performance, identifies areas which needs improvement, provides department specific recommendation, and tracks progress over time. So feedback is very, very important. We need to have in the OR committee meeting, we usually take the feedbacks about all this, and staff education and training. Staff education training with regards to OR, whether it is different department ICU, it needs to be taken care. Like how many air exchanges, what is the positive pressure which needs to be maintained, also, what is the humidity? What are the air exchanges? What are the aseptic techniques to be followed? And when they open a sterile set, they have to look for an indicator. Or if this is a wet set, they have to recall back. So all this needs to be taught to the OR staff, whether it is nurse or a technician or a surgeon as well. And teaching them current techniques of hand hygiene, PP usage, aseptic procedures, and waste management is very, very important. And poor compliance is with the doctors, surgeons. Sorry to say this, but then I see that doctors do not know what to discard there, even till today. Even though we give continuous training, this is what happens. So that needs to be taken care as well. And this continuous training builds confidence and competence among all the employees. So overall, improves adherence to infection prevention and policies, all the three together, reduces the hospital-acquired infection, especially the surgical site infection, and standardizes safe practices across departments and promote continuous quality improvement. That is what, at the end of the day, we need.
Absolutely, ma'am. I think, you used in the end the right word. Whatever we are doing, it is continuity. It is a continuum, right? And that's why, we also named the session also the continuum, right? So there is nothing like, there is a beginning and ending. It is continuous and it goes in cycles and cycles. And we, without actually getting fatigued, we had to move on doing the same thing, repeating the same thing, learning from the feedback, learning from actually audits, making CAPAs better in order to see that, the next day is going to be better than the yesterday. Thank you very much, ma'am. Dr. Ranjit, our landscape of the surgery is changing over a period of time. From very extensive open surgeries, now we are moving into the new era where the keyhole surgeries and robotic surgeries are becoming order of the day, if I had to say so. And of course, it has got its own negatives and positives, pros and cons. One of the pros is, of course, it reduces the SSI risk. At least that is the perception, right? Uh, do you really believe that this shift in the landscape of the surgeries are going to reduce SSIs? And what could be, is it the technology alone which is going to actually reduce, or is there something which we need to do? Maybe an overview on the changing landscape, please.
Yes, sir. This is very true. The statistics actually speak that with the technology like lab, arthroscopy, and robotics, definitely the SSIs are coming down. And this technology is an excellent enabler, but it is definitely not a substitute for surgical discipline. So there is no guarantee that this technology, robotics, labs, or something will prevent infection. There is no guarantee. After all, a bug is smaller than the smallest of the needle which can penetrate the body. So the bugs can enter anywhere. I mean, like, it is just a technology. That technology perspective is for smaller incisions, less tissue trauma, faster patient recovery, reduced blood loss, less complications in comorbid patients, but it is not a shortcut for SSI. There are no guidelines separate for the technology specific. The principles, the guidelines of SSI prevention remains the same. Surgery is a surgery, small, big, emergency, anywhere. You can't breach the guidelines because all that matters is a bug. If there is no bug, it's a different word. So I feel more discipline is what determines. The technology can never underwrite a surgical discipline. So the tissue handling, even if your incisions are small, if you don't handle the tissues, they get infected. If I'm working in a portal of 1 centimeter where I need 2 centimeter for the sake of showing the patient that it is minimal invasive, definitely the tissue is destroyed, and this destroyed tissue is food for the bug inside or outside which is going, and that will get infected. And if you don't use an appropriate antibiotics in that technology, definitely that will not help. So ultimately, it is the sterility, maintaining discipline, maintaining the guidelines, and what we have spoken all for. The technology cannot compensate for any of these surgical habits.
Wonderfully summarized, Dr. Ranjit. If I may have to ask, just for my knowledge improvement, are there any studies, comparing in regular surgeries or the standard procedures to robotic and keyhole surgeries? Is there any difference in terms of SSI rates?
So primarily, I don't think anyone has studied the primary outcomes, but everyone knows that these are small incisions, so obviously they will be low. But definitely as a secondary outcome for most of the advanced procedures, so many evidences, so many studies, and SSIs are reported there. Not that they are not reported. There are some meta-analysis studying all SSIs in these minimal invasive procedures.
Okay.
Obviously, what they have is there are so many factors. You can't label the factors. So ultimately, it is not the size of infection. But yes, there are enough studies.
Yeah, probably for some of the scholars of diploma in infection prevention and control, probably this could be a study you had to take up to kind of weigh between your minimally invasive and invasive surgeries, to see how they are faring in terms of SSIs. Probably that is something what I can take from
Sir,
Dr. Ranjit. Dr.
can I
Ranjit?
just add one thing?
Yeah, please.
Just one thing. So as Dr. Ranjit said, we have to take all precautions for prevention of SSI. There is no compromise there. However, we need to remember that a laparoscopic or a robotic surgery, the patient recovery is very fast. Because the patient recovery is very fast, their hospital stay is less. That in itself reduces the SSIs, which would be if they were for a longer stay. That is one. And second, because they work early, the better perfusion to all the tissues, all that is much better. So all again comes down on the morbidity and mortality. So that's from my side. So yes,
Thank you.
they do better post-operatively.
Thank you for that very important addition to what Dr. Ranjit said. I would skip actually the fourth round because we have already run out of actually our 1 hour. I did not notice actually how quickly it went on. Thanks to all those wonderful insights. Probably I would ask each of the panelists as a closing remark, right? If every participant attending today's panel discussion remembers only one message, because you know that our span of attention has reduced very drastically, and probably the people cannot take too many messages. If there is only one message about preventing SSIs, what would be your message? Maybe we will start with Dr. Bhavani and then to Dr. Kalyani, and then in the last, the next to the gods, that is surgeon.
So one point I would like to suggest and emphasize and pause and whatnot, timely giving of antibiotic prophylaxis. 1 hour before incision is must. And whenever reducing is required, it has to be given on time. I think this can prevent 50% of cases.
Absolutely, ma'am. Very rightly said. Dr. Kalyani, over to you, ma'am.
Yes. Sir, I again also prophylactic antibiotic at the right dose at the right time should be given. That and hypothermia prevention. Take active measures to prevent hypothermia, reduction in temperature in the OT. So those two things would be kind of my goals.
Guys,
message.
all of you carefully listening, I hope, take at least these last messages, which are like, a concoction of all the knowledge, which they have distilled. Dr. Ranjit, over to you.
So my one message is consistency prevents infection. We need to start with one simple change. Simple things like don't use a face mask like this, because this will harbor infection. So OT way we follow, but we need to keep in mind, we need to point things. You need to change the mask every time you remove. It has to be either on your nose or off. No hanging of mask. So small changes do make lot of practice. So something what we have to follow in our daily life.
Beautifully said, beautifully concluded with a remark. Probably we will take some questions to the extent possible. Before that, probably I will try and see, if I can conclude before, we take the questions on very important messages all of you have given. And definitely this discussion has reinforced an important truth to my knowledge, that preventing SSIs is no longer limited by scientific evidence or the guidelines, etc., right? We already know what works, right? We are all the people, of course, although some of these guidelines, etc., were not part of curriculum, but over a period of time, while we are practicing, we have developed the knowledge, reading, the journals, reading actually the guidelines, etc. We have both international guidelines and also local guidelines, national guidelines. We also, each specific specialty also have got some guidelines. All those things are available. Effective interventions are also available. The real challenge, as I said in the beginning itself, is translating whatever knowledge which we have accumulated today and also during our practice, is to see that, how do we get that into the consistent practice. Whether we are going to approach SSI prevention as surgeons, microbiologists, anesthesiologists, nurses, infection preventionists, or hospital leaders, or even industry. One message, which I am taking is that what stands out clearly is safe surgery is the result of teamwork, leadership, and unwavering commitment to evidence-based practice. It is not that, we just do just like that. There is an accumulated experience based on the evidence, which we need to take it and, implement. Technology, like what we talk about, these minimally invasive procedures, or the artificial intelligence, which has become, now a key word for everybody, with, ChatGPT to Cloud to, whatnot. I think Kimi is the latest version. All that would come. Digital surveillance would come. Rapid diagnostics would be there. Smarter operation theaters would be there. All that is going to definitely strengthen our efforts. However, no innovation can substitute for disciplined execution of the fundamentals, what we have learned today. And we can start with something very simple and cost effective, like, for example, hand hygiene or the pre-surgical bathing, right? The speakers have talked about it in multiple times during the last 3 sessions. And I think, that is something which can drastically reduce. There are various studies about the chlorhexidine bathing, pre-surgical bathing, which can phenomenally reduce actually your SSIs. So let us therefore leave this masterclass not merely with the knowledge, but with a renewed commitment to implement at least one evidence-based practice more consistently in our institutions wherever we are working. Every surgical site infection prevented is a patient who recovers sooner, a family is spared unnecessary suffering, and another important step in our collective fight against healthcare associated infections, and also antimicrobial resistance, because we heard about it, how they are linked together. All right. So thank you all our distinguished panelists. I had real pleasure of having these jewels actually coming with such a wisdom, and to everyone who have joined from all over the world throughout this masterclass series. Thank you very much once again. Now we will see if we can use next 10 minutes to at least reply some of the questions you all have posted in the messages. Let me go so that there is no discrimination. We will go to the first so that Nisha invited blah blah. Okay, I'm sorry. I think there are people who are putting their AIs so that they don't need to listen. Probably they want summary. Good evening, ma'am and sir. I Sering Dolma Thakur, working as a link nurse as well as in charge in cardiac department. Just want to know whether we can go for pacemaker implantation patient who is having throat infection and UTI. Maybe Dr. Kaleni, you want to take it, please?
Yes, pacemaker insertion, is it an emergency or not? If not, if it's not an emergency, I would say that the infection be controlled. Especially upper respiratory tract infections. If we give anesthesia, there are more chances of respiratory complications. So for any elective procedure, if they have cough, cold, we do not take them up for surgery in an elective basis. Now coming to emergency, and that is when we tell them the risk and take them up. So it depends on what is the indication. Is it elective or is it emergency?
Great. Bhavani ma'am, specifically, Tirth Raj is asking you only the role of environmental cleaning, HEPA filters, cleaning positive pressure in OT. Maybe you can take this question, ma'am.
So environmental cleaning should happen after every case. Thorough terminal cleaning should be taken at least for 10 to 15 minutes with the best disinfectant. You should also cross-check how they're diluting, how the housekeeping is doing it. So here the policing is very much required, whether it is done by the nursing or the chief nursing over there or the surgeon himself, because it is his case. So I would like the surgeon to have a look how well it is cleaned, because they are so phobia about their patient developing infections. So positive pressure is, it's a must. Positive pressure, we have to check every case. Every case they have to note down in the safety checklist how much of positive pressure is there in that particular OR. So that is also very, which needs to be followed regularly.
Very crisp, and I think it's very, very clear, ma'am. The participants are requesting for environmental checklist and also WHO SSI checklist. I'm sure Manisha, if you have, you can share, or you can request Kalani ma'am or Bhavani ma'am. They will be more than happy actually to provide you with the latest checklist, both for environmental and also SSI. The next question is, in implant box, biological indicator is necessary or not? Maybe Dr. Bhavani, probably it is to you.
Yes, definitely it is required. Every time you run an implant, a biological indicator is a must. Otherwise, also you run per day one biological indicator as per the hospital protocol. But when you're running an implant, when you're sterilizing an implant, one BI is must.
Thank you, ma'am. Dr. Ranjit, one question is regarding if the surgeon is wearing an OT dress and performing OT, that surgeon can go anywhere in OT on the same dress in another OT, also between the surgery? That is the question.
So OT dress is a dress. It is not sterile. I mean, like you can't go and directly operate with it. So it is just a uniform which is comfortable for the healthcare professionals, so that it ventilates you, it absorbs the sweat, it exchanges the air, creates a comfortable. So it is made up of polyspun. It could be made up of a proper cotton mix polybound. So we don't really autoclave a OT dress and wear it. There is a scrub ground which is supposed to be sterile. I think as long as your OT scrub is not contaminated with the body fluids, contaminated with some kind of positive infection in forms of fluids or something which is gross, that might spread infection. I don't think you need to change a clean OT dress, and definitely within the OT premises. Within the OT premises, it is not practical otherwise.
Yeah,
And if
thank
I
you.
may add, there is no evidence that you need to change. So they say in the OT, don't wear clothes which you wear from home, only because the dust and tetanus will come. This is just a freshly washed set of clothes, which, as Dr. Ajit has said, is comfortable. So there's no evidence that it has to be sterile, and we can, within the OT premises, we can walk around.
I would like to add upon that. So scrub is the dress which is worn by them, by the
Yeah.
anesthetist or surgeon. During surgery, they're anyway going to wear a sterile gown. So I think scrubs are allowed in between ORs, but not to outside.
Great, ma'am. Maybe, just continue with that, Dr. Bhavani. Somebody is asking, how much is the time gap to maintain after fumigation for air agar plate?
There's no fumigation. Fumigation is not
No.
required. So 10 to 15 minutes is what is the recommended time for thorough terminal cleaning.
Yeah, I think colleagues, we talked several times in the past also. As per the latest guidelines, there is no fumigation required unless there are indications like, you have newly opened it, or, you have some contamination happened and the evidence is there, or, it is a rebuilt environment, etc., etc. Those are the specific situations. Otherwise, fumigation as a standard procedure is not followed. I think, that is what has been emphasized several times by the esteemed speakers in the past too. Probably this would be the last question. I probably would request Dr. Ranjit to take this question. In our hospital, post-laparoscopic surgery, every patient comes with pus discharge after 60 to 90 days from the port site, and the ulcer looks indurated, and clinicians are suspecting NTM, and also patients are not responding to any antibiotics. What to do in such situations, sir?
Check your practice. I mean, like, we don't know. We might miss out something which is important. But if, sir, it is 60 to 90 days after.
Yes.
So that doesn't come under SSI. But still, if every patient is coming, there is something wrong. Seriously wrong. And you need to check back right from basics, audit yourself, learn yourself, try to identify yourself.
Very
Can I
well.
add something? Can I
Please
just
do.
add something? So what happens is the umbilical area is the common site. So now all these surgical specialties, they spend 5 minutes cleaning the umbilicus. And if that is the site, it is because the preoperative cleaning has not been done properly. That is the most common site for infection. So in our hospital, specifically 5 minutes is spent just in cleaning the umbilical port site. I don't know if that is the thing, but that is common where the infection occurs.
That's a great insight for me, ma'am.
So I would like to add, if that laparoscopic, whatever can be detachable, it can be sent for plasma sterilization immediately. I think this can prevent infections.
So, colleagues,
added, sir, yes, that is true. Most of the places don't have this plasma sterilizers and everything. So that practice of using inside X or just cleaning with sterilium or something could also
Yes.
be a basic.
Right. So ETO also can be done if that is available. Or go to Sidex. Sidex immersion for at least 15 to 20 minutes is preferable.
So, like every good story had to come to an end, probably we have reached that end today, and with a lot of satisfaction, with a lot of learning, and with a lot of key messages. I am going back home. I hope you also have, all the participants, you also have a lot of insights, a lot of key messages, which you are taking back home. But just don't sleep on those messages. ensure that at least one of those messages, one of the key takeaways you are going to implement tomorrow in our institution, so that our journey towards safer patient safety is going to be a reality in one day. Thank you very much. And to all my wonderful panelists, I would like to say my heartfelt thanks. And thanks to all of you colleagues. Have a great day. Thank you.
Thank you, sir.
So thank you, sir, for this wonderful discussion. Thank you. Thank you, Ranjit.
Thank you, ma'am. Thank you, sir.
Thank you,
Thank
Dr.
you.
Kalyani and
Thank
Dr.
you.
Vijay and Dr. Rangareddy.